A good friend, Howard Scher, who's got this Herculean task of telling us all about the future of prostate cancer in 20 minutes. But he can do it if anybody can, and Sandip Prasad will be the discussant.
Well, we'll certainly give it a shot. So thank you, Neil, for the invitation. This is my first time at this meeting, and I must commend you on the focus of the meeting and really thinking forward. I was asked to talk about the future of prostate cancer, and I think there are two major issues that we're seeing more and more is how do we integrate genomics in our practices, and also how do we make decisions? Because we're getting to the point where these tests that we have are so sensitive, and our reaction is to react very, very quickly, and in some cases this may not be in the patient's best interest. So here are my disclosures. So I would just remind you, this is November 1st when we start growing mustaches for the Movember group. This was started in Australia over a decade ago, which really focuses on men's health, and they've had a major, major role working with the Prostate Cancer Foundation, supporting state-of-the-art research that is really improving the lives of men with this disease. So just as a framework, I'm going to go through a little bit of the background, how a biomarker is developed. Many of us are familiar with drugs. Where are we now in terms of the drugs? Talk a little bit about taking the fight early, because we know the genomics in early disease is much different than later disease, and how we're starting to use other non-invasive markers to monitor disease and also to identify predictive biomarkers of sensitivity. I'm sure all of us share one thing, in that we get thousands of emails over the year about a new technology or a new advance that will transform care for our patients. And realistically, all of these technologies are producing biomarkers which really have a development path that is different than developing drugs, and a few people understand. There's also been some confusion, I think, about what is personalized medicine versus precision medicine. And if you see a patient who walks into your practice versus someone who's coming in limping, you have essentially made a biomarker decision. The reason it would not fit as a diagnostic test is that there's subjectivity in that interpretation. But when we start thinking about precision medicine, we start thinking about biomarkers that we can measure reproducibly and quantitatively that help us inform decisions with respect to our patients. And this is a definition from the European Society of Medical Oncology, which says precision requires the ability to characterize precisely the molecular and cellular features of the tumor and its microenvironment. Think of that as the neighborhood in which it is living, taking into account genetic markers and lifestyle and environmental factors unique to the individual. And ultimately, we're trying to make better decisions so that patient outcomes are improved. So we're all familiar with the use of drugs. These are approved for a specific indication, an unmet need. Biomarkers are developed for a context of use, which you can think about as what is the decision you are trying to inform. So again, there are a group of assay developers that are talking about how do you understand prognosis of localized disease. As oncologists, we're focusing very frequently on how do we choose which drug to use at a particular time, a predictive biomarker. We talk about response monitoring. Is the treatment working or is it not working? And ultimately, we would like to show a surrogate. So if we're looking to see if a drug prolongs survival, is there an early measure that we can look at that says we can reliably predict that this will be a surrogate replacement for survival so the drug could be available early? And there actually is a new criteria that's been posted on the FDA website called the BEST criteria, biomarkers, endpoints, and other tools. I think it's worthwhile looking at because the definitions have changed. One of the key things about any test is its reproducibility. And the first thing we do with any new test for any new biomarker, molecular, or protein is to kick the tires. Does the assay give us reproducible results under a range of conditions? And if you are a developer of a drug, you have a formulation of the drug which stays constant all the way through development. The same holds for a biomarker, is that once you have committed to an assay, you are married to that assay through the entire development course. If it's changed in any way, you need to start over. Clinical validation really covers how do we start associating a biomarker result with a clinical outcome. PSA used for early detection. It's also used to monitor disease. again, we are generating evidence, and ultimately, we're looking for clinical utility, which is simply stated to show that the use of the test result to inform a management decision results in a better outcome for the patient. Patient benefit. It could be avoiding a toxic, expensive drug that doesn't work, in contrast, using one that ultimately will. Now think of this in terms of different stakeholders. Physicians, I have a cadre of tests I can order. Why this one? Why now? Will it help me better manage my patients? From the patient point of view, will this test help me understand and treat my cancer? Think of it, should I pay for this test? PSMA scans are not universally available. We feel they have a role in many different contexts, and that will, in fact, change management. For investigators, will it facilitate my research? For sponsors, will it accelerate the development of a drug? Regulators are looking, should we clear it? Should we, and insurers are ultimately looking, should we reimburse the test, as costs can be quite significant. So where are we now? Again, there's been huge progress in the number of drugs that are not available. We've also made huge progress in understanding the biology, and we're starting to develop a biologic classification of prostate cancer, which are, each of which is responsive to different classes of drug. But keep in mind that what we're seeing now is not what we saw then. Registrational trials for abiraterone and enzalutamide as examples were done in the first-line setting. Now we're using these agents, including docetaxel, earlier in the disease, and we're actually changing biology to the point where the patient populations who were enrolled on these registrational trials, in fact, don't exist, which makes it difficult to inform decisions. So what we really need to do is think about how do we generate the evidence to show that we can make our decision-making better. So now, if we look in 2018, we have 7 approved drugs. You can see where they were positioned. We previously thought of first line, second line, third line. You'll see that that is now disappearing. We have drugs in the non-metastatic space based on a radiographic progression endpoint. We also have the first drug that was approved exclusively on the genetic characteristics. That is the pembrolizumab, and in fact, that trial didn't enroll any prostate cancer patients. But we know that there are subsets of patients with prostate cancer who have the genetics which would predict for response. We have a class of drugs called PARP inhibitors, first of which is olaparib, and as recently as last couple of weeks, rucaparib also have what's called a breakthrough designation, which means that the data in the phase 2 trial was significantly positive for the FDA to bring all hands on deck to accelerate the availability of that study. And if we think about now major profiling efforts, this is one sponsored by the Stand Up to Cancer Prostate Cancer Foundation profiling effort, not surprisingly showing that the androgen receptor, the AR, is the most frequently altered pathway in castration-resistant disease that we used to call hormone refractory. In fact, in many cases, it's hormone hypersensitive. We're seeing DNA damage repair alterations in 15 to 20% of patients, and the PI3 kinase, which has been a little bit harder to target. But again, we are starting to get into these molecular subsets for patients, and this is how we are now focusing on drug development. We also learned that a significant proportion of patients have germline alterations, and this is almost independent of ethnicity. So in point of fact, based on this frequency, about close to 15% in our population, we are routinely doing germline testing on every patient that we see, along with profiling of their tumor. But as I mentioned now that before, we're now using the approved drugs early in the treatment course, and the standards of care are now changing. So whereas we would typically think of using docetaxel, abiraterone, enzalutamide in the castration-resistant state, they're now being used much earlier in the course of the disease. And in point of fact, as I mentioned earlier, the populations that we see as castration-resistant may have seen 2 or 3 of the life-prolonging drugs and are likely to be very, very different, which is why we have to start focusing on understanding the changing biology in order to make better decisions. So again, when we were first trying to create a database of prostate cancer, we asked the question, what is the stage of a patient who has a biochemical recurrence? And the answer is there isn't any. The prostate is out, and we decided instead to think more about clinical milestones. So patients know if they're diagnosed with a clinically localized cancer, if they have a biochemical recurrence, if they have metastatic disease, if they're castration resistant. And again, this is how we focused our drug development, because each of these states, the issues are different, the endpoints will be different. So think about the past and how it informs the future. So we think about each encounter, each visit as a new, essentially a new visit. If somebody has had a recurrence after prostatectomy in 10 years, that's a lot different than the patient who has a recurrence within 1 year. So all of this information, again, needs to be integrated in order to develop the approach that we would use going forward. So we'll look at the characteristics of the primary tumor. We'll look at was the prostate treated or not. We'll look at disease extent, host factors, and also in biology. But don't throw out the information that essentially comes out of routine practice. LDH, for example, if going up in castration-resistant disease, is a very poor prognostic factors. So we understand now that the biology is changing, so the unmet need is to identify those predictive markers that say take drug A versus drug B. And clearly a focus now is how do we deploy the agents optimally for the individual patient, and how do we identify subsets of patients for whom a specific class of drug may be most appropriate. At Memorial several years ago in 2014, the Center for Molecular Oncology was launched. This is the test we now use is a next-gen sequencing assay that was approved by the FDA in November of 2017. And the way that it was approached with each disease group was to give the first 50 tests for free. Any more than that, you need to pay for them out of your own funds. We've done 1,800 prostates. Together, the group has sequenced over 30,000 samples. All this information is available in a central database. And as I'll show you, there's a group that actually annotates the significance of each of the findings and will tell you if there's a drug that's approved for that particular target that's identified in that patient. But this involves continuously, as the techniques for sequencing and understanding biology improve, there's an innovation group that's working with those to see when they're ready. And we are launching our first cell-free DNA pan-cancer test called MSK Access within the next month. So essentially, we get the tissue from outside. All patients are consented. Again, the DNA is captured, make sure there's a sufficient amount. Next-gen sequencing is done. And again, an analysis is reported. What essentially happens, as I mentioned earlier, there is a level of evidence. Level 1 essentially indicates that for the target identified, there is a specific approved drug, all the way down through, is there a protocol available for this particular patient? And again, this helps us in terms of decision-making because we can pull these up in our, during practice. Now, this poster child for having available targets and drugs is small cell lung cancer. If you look at the list on the left, you can see the largest green line is for of the common solid tumors is lung cancer. You can see the prostate cancer. There is no green, so there is no single test that says use drug X that's approved specifically using a prostate cancer. And if you look at prostate cancer on the right, you see there's a collection of changes on the left, but what we call the long tail of a series of 2% alterations that would be almost impossible to try and develop individual trials for each of these targets. So we're different. We don't have the traditional mutations you find in other. What about the immune approaches? So again, as I mentioned earlier, the microsatellite instability can be measured with a specific biomarker. And if you look at the frequency in different diseases, I've highlighted in red prostate cancer, it's about 2%. And as mentioned, we would never be able to complete a trial in a timely manner just enrolling prostate cancer. But in point of fact, we've identified over 70 cases now, and you can see on the right the PSA patterns for patients who were treated and the favorable radiographic changes. So again, we can use this drug if we identify that there is evidence of microsatellite instability within the tumor specimen that we analyze. And again, I could say we're pretty encouraged when we see this, because this is not what would not be a traditional, something you would necessarily think of without the data. So what about taking the fight early? This is a report that was put together by Dr. Abita, who's one of our junior faculty. And again, we're not really trying to look at the individual genes, but just look at the amount of color. On the left is localized disease. In the middle, non-castrate metastatic disease. And on the right, you're seeing the castration-resistant. This is just the androgen receptor, and you see the frequency of alterations is quite low. You're starting to see amplification in the non-castrate metastatics, and look at the castration-resistant, much different. This is the DNA damage repair pathway alterations. Again, relatively infrequent in localized disease, a higher frequency in castration-resistant disease. And if you start looking at the circulating tumor cells in these populations, when you start getting into third line, you're treating multiple cancers at the same time. And we've shown that with a targeted agent, you're not going to have a lot of success because many of these cells are simply different. Now, if you just look at a series of genes on the lines, you can see the localized disease versus the castration-resistant. You see the frequencies of individual alterations are much higher. So we thought about, why not take the fight early? We have drugs that work in castration-resistant disease, and the question is, could we develop a platform focused on eliminating all disease and getting patients down to a minimal tumor burden where the drugs are likely have a chance to eliminate everything? So the hypothesis we're exploring is that with the level of efficacy we see in castration-resistant disease, analogous to what's seen in other tumor types where the disease can be cured even in an advanced disease setting, if we use these early, and everybody brings their A game, the radiation oncologist, the urologic surgeon, could we actually eliminate disease? So here's what we call the Medicure platform. It's a master trial which enables us, similar to Stampede, to test many different drugs in a sort of a rolling manner. And because of the ambiguity of what's advanced localized disease, we decided we would just take the clinical spectrum from high-grade localized disease to the biochemical metastatic recurrence, which is now being identified more frequently as choline, Axemin, and PSMA scans are being used, to low-volume metastatic disease. You notice I avoid the term oligometastatic because I'm not sure what that is. But again, this is the continuum of patients that are included. The objective is to eliminate all disease. We have 3 different cohorts. Listed here are the patients who have locally advanced disease, high risk. B1 are the retroperitoneal nodal patients, B2 are those with bone metastasis. And ultimately, the intervention involves aggressive local regional therapy to aggressive systemic therapy to start, local regional therapy, which includes radical prostatectomy, pelvic lymph node dissection, and in those patients with retroperitoneal disease, RPL&D is very similar to what's done in testis cancer. Radiation therapy is given to visible metastatic disease, and the eligibility in the protocol limits the patients to 3 isocenters based on a bone scan. And this is what it looks like schematically. Again, we start with systemic therapy, and about before the timing of surgery, patients are getting stereotactic body radiotherapy to the individual lesions. This is followed by aggressive surgery, and then all therapy is stopped. The marker we're looking for is a pathologic complete response, which is an approvable endpoint in breast cancer, and based on work by Mary Ellen Taplin, minimal residual disease. And we stop therapy and look for testosterone recovery in order to call a patient to having set the endpoint. Again, this is recently started in June, and we're ready to recruit about 15 patients. So for the last part, I want to focus a little bit on blood-based profiling. And as I mentioned earlier, we don't know the optimal sequence in which to administer drugs. So we're paying more attention into what was given and the sequence in which it was administered, because this we think is more relevant than just doing pre and post chemotherapy. But if we wanted to understand changing biology, you start doing biopsies, and you have issues, because if you do a bone biopsy, you only have about a 50% chance of getting adequate tumor to profile. The primary tumor we know is yesterday news and out of date. So ideally, we'd like to work in blood tests, and there are a variety of tumor materials that can be assessed. We'll focus on circulating tumor cells, but there, again, a number of groups are looking at circulating DNA, microRNA, exosomes, microvesicles. Again, a very active area of investigation, but we'll focus on CTCs. And we've been focusing primarily on the decision to determine what drug to use at a particular point in time. This is the PSA waterfall plots, each line representing an individual patient, showing the percent decline in PSA from baseline after treatment. In the orange color, you have abiraterone superimposed as enzalutamide, and you can see pretty clearly you can't predict what's happening in the second decision based on the first one. There are patients who respond to both drugs, some to one and not the other, and some that are resistant to both. So we would call this an unmet need for which a decision to understand who might respond to a second agent would be useful. And if you look at this schematically, we've been focusing mostly on drugs that are already approved and in use in practice. So with a high frequency of response in the first-line castration-resistant setting, we don't think you really need a test because most patients will be treated with a high likelihood of success. But in the second-line setting, where you can't predict how somebody's going to do by sequential androgen receptor signaling inhibition versus a taxane, that's where the test starts to become informative. So we looked at second, third, and fourth line, and we were looking for a particular predictive marker which would predict for sensitivity to the androgen signaling inhibitor. So this is a schematic showing the androgen receptor. It has a N-terminal domain, which you could think of as the accelerator. It has a DNA binding domain, a hinge region, and then the ligand binding domain where the various anti-androgens and testosterone bind. If you look on the bottom, you notice that there is missing the blue portion, which is the ligand binding domain. And what I've highlighted is one of the splice variants, which is called ARV7. All of these splice variants can activate the receptor signaling axis without the ligand present. And based on work done at Johns Hopkins, they were one of the first to show that if that ARV7 was detected, patients did not respond to an androgen receptor signaling inhibitor, and preferentially their outcomes would be improved if they were treated with a taxane. So again, there are a range of assays that have been reported using this, and I'll be focusing on the one that we worked on in collaboration with Epic Sciences. This is a CTC identification platform that uses no selection. What essentially happens is a blood sample is collected in a tube with a preservative. It's a Streck tube. The red cells are lysed. The entire cell population is deposited on a slide. It's about 3 million events. It's scanned. The slide is then scanned after staining, and various cells can be identified. And what you see on the right, a range of features can be looked at, almost like think of it as ethnic profiling or facial recognition, which is something we're now applying going forward. But what we're going to focus on now is just the detection of the ARV7, both in terms of detection and where it was located. So again, we used an exon-specific antibody to the unique protein that's coded by the splice variant. If you look on the top, you see the full-length androgen receptor structurally. In the bottom, you notice that the green portion is truncated. The antibody identifies that green portion. And on the right-hand side, you can see on the top that there is staining within the nucleus. On the bottom, you can see the staining is primarily cytoplasmic. And we would postulate for something that's going to drive signaling, it would be important that it be localized in the nucleus, and this determined the specificity of the test. Here is how we looked at the association, having an assay that was fit for the purpose of exploring this question. And what you look on the left is the PSA waterfall plot of the first line, second line, third line cohorts. Each of the sort of gold bars are patients in whom circulating tumor cells with the ARV7 present were identified. And you notice that all of those are going up. These are non-responders. And all of the downward PSA declines were in patients in whom the ARV7 was absent. Again, what you notice as well is that there is blue on the top. So the ARV7 is not the whole story. And we're working to see if we can expand that predictive power to other drugs. What you notice in the middle is the survival difference between ARV7 positive patients and the ARV7 negative, the more favorable outcome in those who don't have it. You also notice on the top right that there is, if you want those patients who are ARV7 positive are treated with a taxane, their outcomes and survival is better. Below, you see what happens if you don't account for localization, and notice the curve on the right. You see that the treatment-specific interaction showing that there is a survival benefit with the taxane essentially disappears, and you start to see some downward PSA declines. This was validated independently on a separate cohort of specimens. The top right essentially showing, again, the treatment-specific interaction. Use the test as ordered, and you will see a survival benefit in terms of treatment choice. This received a favorable, was licensed to Genomic Health, and is received a favorable coverage recommendation from Medicare. The proposed use of the test was posted on October 8th, and the comment period will end on November 23rd. But really, what we're facing now is, when do we stop treatment? So here's a patient of mine. You notice that his PSA dropped and then rising slowly. He was a patient who had osseous disease, came in with symptoms that we identified as related to his golfing rather than his tumor. And we were able to follow him with a slowly rising PSA without radiographic progression for almost 3 years. But as we start being able to detect small frequency mutations, we have a problem. We can't act on all of these, and understanding when to do so is a critical factor. So we've come up with this category we call no longer clinically benefiting, which we developed with the agency, where we're trying to recognize the heterogeneity of the tumor, and it basically allows you to be a doctor and not have a protocol mandated or some automatic stop without thinking about what's going on in an individual patient. An example, a patient with severe pain whose PSA is going up. If you have a drug that controls that pain, he's not going to want to give that up. So again, this enables you to continue. But if we're doing this in trials, we have to say why it stopped. And here's an example. Notice the patient on the left has diffuse disease by PET scan. Treatment disappears. PSA starts rising. Don't see any changes. And later it continues to rise, and he's only progressing in one location. So again, with SBRT, this patient has been controlled, and his drug has been continued throughout. Just very briefly, I'll go through some of the issues with the PSMA testing. Here's a typical patient. We see multiple cores positive, Gleason 7 disease, PSA 7, Gleason 9 disease. Bone scan looks clean. You have to debate it. Do a PSMA scan. It's a totally different picture. So the definitions of metastatic disease are changing. And here you can see you can actually use PSMA also to monitor disease. And here's an experience where you're using lutetium-177 PSMA-directed radionuclide therapy. This is a series from Australia, and you can see the response is really quite significant in a very heterogeneously treated group of patients. This is now in phase 3 development in the US as well as elsewhere. So what I've tried to walk through is, how do we make decisions? We need to understand what biomarkers are and how they are developed when we're weighing the evidence to make decisions within our own practice. We have drugs that work. I think this approach of taking the fight early, like it's done in other diseases, will pay off, but we're asking the question. And with advances in the blood-based diagnostics in PET, we're seeing the disease very differently, and I think will improve patient outcomes, just being very thoughtful about when we stop or discontinue drugs. I want to thank all my colleagues. Again, this is an army that works together on this in our biomarker program, and I thank you for your attention.
Thank you. I just have a single discussion slide. Howard, can I grab the clicker? So I think those of us that work in advanced prostate clinics are very grateful for the opportunity to practice personalized medicine with ARV7 testing, and we routinely order this in our patients. I think this is clearly a success. It's fairly straightforward to use. It's a very defined clinical space. We're seeing our MR, CRPC patients who are on one therapy. They get tested, and there's really a binary outcome from this test, and it's very useful, very clear to explain to patients, and I think very helpful with significant benefits in overall survival. I think where I personally struggle and where my discussion will really lead us is to the many clinically available multi-gene cancer predisposition panels. So I'm going to go through all the questions, and then you can please answer them as you see fit. But really, I struggle with who to test. So sometimes patients walk in my door with these tests in hand. They tell me they have a BRCA2 mutation, and what should we do? We know that these mutations are present in really only 5% of high-risk prostate cancer and much less in low-risk prostate cancers. That being said, these tests are several $100s only, and so the utility and the ability to adopt these is fairly easy. Second is when to test, and I agree with your take the battle early, but should we be doing this before diagnosis? In terms of when we use these agents, should it be used in the pre-metastatic setting? And as you alluded to, does this actually change the timing indication for our PARP inhibitors, platinum-based chemotherapy, which we know may have a role here, and again, using it in various points in the timeline that we really, it's quite disruptive to what we're doing today. And really the last is, when patients come to me with these tests or when I order them, I don't know how to counsel these patients. And many times I find that I try to be very limited in terms of what my recommendations are, but in terms of future counseling for screening, for downstream family relatives, I struggle with that. And again, any of those you'd like to tackle?
So again, we're not, the patient who we're referring for active surveillance, we're not doing genetic testing either on a germline unless there's a predisposition. But what was important is that family history alone isn't insufficient to rule out the presence of potentially targetable alterations. Through the Prostate Cancer Consortium, we're working on how do we identify those patients who really need to go to a genetic counseling, and how do you take the information that you're getting from the routine tests to analyze that? And there should be a white paper coming out, two efforts, one from a combined effort at the University of Washington and Memorial Sloan Kettering. So these will be helpful, but we were completely overwhelmed by this, as I know a lot of people are, but we think it's important. Everyone's going to have to decide for them what frequency of detection will be your threshold. The MSI high, again, it's a low frequency, but when you see it, you have a curable option. So it's hard to not do that. And in fact, that's what we base our decision to actually do the next-gen sequencing. We're not billing for the other tests. So most important is to show what a specific alteration means with the trials. I think, in the DDR field, there's a lot of differences in the actual assays that are being used. And there was a very nice report, not nice, but from Ken Pienta's group at Hopkins. They took the same sample to two different labs and showed very low concordance. And one of the key factors was what level they called positive. So when you're looking at a test result, you have no idea what the computational pipeline is or the criteria. So this is why we're looking to get some consistency. If all groups would at least lay out the information in the same way. The important thing here is that no test is wrong. It's just each test, if it is giving a different results, needs to be independently tested, and you can't compare apples to oranges. I think that's the most important. It's not critical of the assays themselves. It's the evidence associated with that test result that's critical.
All right, fantastic. Thank you very much, Sandip and Howard. It was great. So we're going to take a